Now's the time for questions. If you want to come up to the microphone, or everybody's leaving. They want to go do this.
They may be done for the. They may be done for the day.
That's right. That's right.
They're headed to the club to try out their new moves.
Yeah.
Can we spoil your day a little bit by telling you that New England Journal had 3 weeks ago 2 studies that said hypothermia does not work?
Yeah.
It did.
No, I won't. Then I won't tell you that.
Yeah.
All right. I think we do have a question over here on the right.
I had a really quick question for the whole panel. When it comes to DVT and PE, Xarelto was given the indication in November of 2012
Yep.
for treatment. So, you know, if I see somebody who's pretty stable, I just start them on Xarelto, make sure they get their first dose there, and if they can afford the prescription, just send them out the door. Is there any problem with that?
We don't have any experience with it.
No.
We don't know nothing.
We don't know.
I have to tell you, I'm not one, especially in a drug that has, I'm not one to be the first to prescribe drugs like that. If a consultant says, I will follow the person, etc., but Xarelto, if they miss a dose, they have the risk of stroking. There's a huge black box already on Xarelto that says don't miss a dose, because now you have an increased risk of stroke. So it's all scary stuff. I find those agents really frightening, to be honest.
It was William Osler that said, you never want to be the first person to use a drug, and you don't want to be the last. I think we're in the realm of the first people using the drug. I'm sitting tight on that one.
Yeah, me too.
Just don't know enough.
You know, all the drugs that are on the Y, you know, the intrinsic pathway, extrinsic pathway, common final pathway, all those drugs that are either making you procoagulable or anticoagulable, they all have narrow therapeutic indices. And when you mess with the Y, you pay.
Here we go over here.
If you're in a facility where you're having to send out your hip fractures and your femur fractures, which, if any, do you splint, and which splints do you use?
So femur fractures, that's easy. They should be splinted. They're not easy to splint, so you can do what the EMS does. You can put a Sager splint or something to try and keep them out to length if they have that. In the absence of that, you can do a long leg posterior molded splint. It's hard to do. You got to snug it in. You want it to go all the way up to the gluteal crease when you're doing that. And you can boxcar it with some bias, you know, put a side thing on it. Basically, you're trying to get them, 1, out to length, and 2, reasonably well immobilized for the transfer. Those are your 2 goals, out to length and immobilized. The Sager does both. Even with a Sager, though, you got to ask the question, how long is the transport? I wouldn't want to be in a Sager crushing my nuts for an hour. You know,
that would be,
yeah. So
He quite has a way with words.
in my
let's just say
situation-
groin erosion would be an issue.
In my situation, the shortest transfer would be an hour.
Yeah, so I would go to PM molded splints with sidecars or box cars, if you like to call it that, whatever.
Good enough.
Do you want to explain what a boxcar is?
You know, where you put another, so you have the PM splint lying behind. Here's the foot, and here's the splint, and then you go from the side of the foot and put another stirrup that's going to come along the side that's going to give enhanced stability. But the key thing is to try and get them out to length. Once you get a femur out to length, you can also strap the ankles together for transport, and that will work. Now with hips, you got to ask what position they're in to start with. If they're non-displaced, I'm going to leave them where they are. If they're displaced, you know, attempting to get those out to length can be a real problem. So most of the hips are going to be as they lie. If you put a hip in, if it was a dislocated thing and you're referring it and you've reduced it, then you want to put an abduction pillow in there. And regular pillows will work. If you have an actual styrofoam abduction pad, that'll work.
Thank you.
Very good. Let's go over here on the left.
Dr. Birnbaum, if you see a patient in the emergency room with fully controlled atrial fibrillation, you don't know the duration, you get them slowed down, now you want to anticoagulate them. Can you start them on PO warfarin safely? Do you think you should start him on enoxaparin for a few days first in case he has a hypercoagulable state? Or do you give him something like Pradaxa? or
Right, so
you got to
I'm
be
not
sure
at
he
the-
gets follow-up somewhere.
Right, so I'm not, the, sort of akin to the, I don't treat DVTs with the new drugs, I'm not gonna be on the Pradaxa line either. As far as with the procoagulant issue with warfarin, it's probably overblown, but it is sort of a standard practice to at least give at our institution low molecular weight heparin.
Yeah, a little molecular weight
So we
heparin and
give
follow.
injections of 5 days of low molecular weight heparin, and then we send them home on warfarin.
Yes, sir.
Ask a second question?
Of course.
Do you either inform patients or obtain alpha-1 antitrypsins on the young first spontaneous pneumothoraxes?
Boy,
I don't obtain the alpha-1 antitrypsin testing or genetic testing. If I see something like on a spontaneous pneumothorax, it's called the angel wing pattern, where they look like they might be marfanoid or have something like that, I will say you might need tested for that. But other than some obvious anatomic morphologic indicator, I'm not seeking biochemical testing on them. And it's certainly not on a first one anyway. If it's someone who's had recurrent problems, you can start asking those questions. But even in recurrent pneumothoraces, it's more often not a connective tissue disorder. It's much more often pulmonary blebs. So they have congenital pulmonary blebs more than they have some connective tissue disorder. It is true that Marfan's will get you here, and there's a variety of other connective tissue disorders that can get you there, even some other things like Turner's. And when you get into the genetics of these things, some of these people are mosaics, so they don't manifest the full spectrum of the disorder. There's lots of Turner mosaics out there, for example. And so even on them, testing can be inconclusive or misleading.
Very good. Over here on the left.
No.
What are your recommendations for upper extremity DVT and below calf DVTs?
okay, so start that, I didn't hear the very beginning.
Upper extremity DVT.
What about them in particular?
Do you recommend treating or just following them with ultrasounds?
Oh, definitely treat.
Treat.
Definitely treat. But most upper extremity DVTs these days, we make happen. They're from the lines that we leave in people. And the issue with that is most of the time you leave that line right where it is and you put them on anticoagulation.
And the other form of upper extremity DVTs that you'll see are in young athletes who are weightlifting, in particular with bench pressing. It's called exertional thrombosis or Paget-Schroeder syndrome. And you'll see that, we see that primarily in our jail patients.
We actually saw that.
They got nothing to do but work out.
One of our residents went on vacation and his wife was carrying the luggage. And she got an upper extremity DVT. He caught no end of grief about having his wife carry all the luggage, and she ended up with an upper extremity DVT.
So those are, and you'll see those occasionally. They'll have sort of a vague ache in their arm. They often don't have that much swelling to it. Late in the course they will, but they often don't have that much swelling. And with the bench pressing guys who are bouncing is often what's happening. What's happening, they're getting this huge surge in intrathoracic pressure when they're lifting. They get retrograde jets of venous blood, which rough up the basement membrane of their large veins in their upper extremity. And then you have a couple of elements of Virchow's triad. You got the roughed up basement membrane, you got reverse flow or stagnation, and that's enough, 2 out of 3, to get the clot off. The thing that's weird about them is sometimes they're bilateral, because you don't bench press with one arm. So they come in with both arms aching, and the first time you see that, you'll be like, what? I don't know what's going on. But if you look up Paget-Schroeder syndrome, which is exertional upper extremity thrombosis, you'll see that this happens. And we see it not that uncommonly in our jail patients.
And same thing for below calf DVT?
That's a bigger mess.
That's a bigger. I think you'll probably get 4 different opinions on what to do about lower extremity calf DVTs.
The answer is treated.
Well, the recommendation these days from the big boys is to treat it. If you look at the VTE guidelines that came out in November 2012, it's recommended to treat. The theory being that the propagation is the problem. Now, not everybody propagates, and you could probably nuance that some. If somebody has it because they were, they're a hypercoagulable person, that's a whole different ballgame than somebody who maybe, was immobilized for a little while and that's it. But I think most people recommend now treatment.
Or another sort of common cause of some of these is they had calf trauma. if it's a consequence of trauma and swelling, then you get into maybe the treatment should be short term. You're worried about them rebleeding because it's a traumatic cause, et cetera.
Thank you.
Very good. Let's see.
We tried to dodge those questions. You're wily.
Yeah, Wiley.
Yes, sir.
Yeah, hi. I was just had a question about the use of TPA in resuscitation and like what your experience is with that. What type of patient we might consider that in, young versus old. I would think that you might consider it more in a young person who, who comes in, and, a 35-year-old or something. And the other thing, kind of the medical legal, if there's any medical legal cases of that happening, people, doctors being sued for that.
I think there's no, as we said before, there's no definite indication for giving TPA. However, I would say some caveats. If you had a history of somebody who, has a history of hypercoagulable disorders, or you had some strong suspicion that you actually thought that they had a PE or something that you knew was responsible for their arrest, certainly they're dead. What's the harm in trying TPA? But giving TPA just willy-nilly probably doesn't have much in the way of benefit. You can look at it the way that, what else? Why shouldn't I try it? They're dead. If I don't try something, maybe I'll get them back.
You get sued for wrongful life.
So
But-
the PE situation in a young woman postpartum is a classic story. She has a sudden arrest, particularly if it's a PEA arrest where you're looking, PE is really at the top of your list. You got the question, all right, how postpartum are they? Am I going to have a lot of hemorrhage there? But I think that's a scenario where people entertain going right after the lytics, because going to the cath lab is not going to help them. So one is a PEA arrest where PE is at the top of your list. Those are the times I'm entertaining the most. In ACS, for acute coronary syndrome where you're treating an MI with it, the fact of the matter is, and I'm spoiled, I'd be the first to acknowledge it, I work in a PCI-capable place, so I'd be much more likely to go straight to cath lab with them than to go with lytics. If you're not in a place where you can do that, there's a German paper we looked at in the abstracts that said they're giving lytics to all their presumed acute MI arrests.
TPA or TNK in those cases?
TNK.
Yeah.
They're giving, because obviously it's easier to give in that setting, and they're doing it, and they say that makes sense.
But I don't think that's standard practice. So
No, I'm not
so part
offering
of
it up
that
as standard.
No, but I do think the dilemma would come up is if you're not in a PCI receiving center and you get the post-arrest patient who has ST elevations that look like they're in a vessel distribution, and you don't have PCI close enough. That's the only time I think you might be able to give it with good justification and logic that's behind it.
Will you guys use ultrasound at all to see?
Yeah, well,
right
ultrasound's
Can be
really
helpful.
helpful.
Wall motion.
Yeah.
So in the PEA arrest where you're trying, so an ultrasound can pretty quickly confirm that you're on the right track for PE, because you'll see a huge dilated RV, an abnormal RV collapse index, a dilated IVC, all things that are indicative of a right ventricular outflow obstruction. That in the setting of a PEA arrest really moves you with fairly high confidence to a massive PE as the diagnosis, particularly in a young person where they have PE risk factors. So that setting, I think that a lytic is the right thing to do.
Thank you.
All right, next question over there on the left.
I just had a comment from a conversation we had this morning with regards to rabies prophylaxis. And we weren't sure what to do with people who had their post-exposure prophylaxis.
Looked it up?
I did look it up.
Nice.
And I actually talked to a vet friend of mine to make sure I was on the right page, because he deals with this all the time. And if you've had your IG and your 4 doses with your original exposure, you don't need to get IG on your second exposure, and you only need to get the first 2 doses of your vaccine. And it doesn't matter how far it's been from your first time to your subsequent. So if 6 months later, if you get exposed again, you need your
doses.
dose 0 and your dose 3.
Perfect, thank you.
Thank you.
Good. Thanks
Appreciate
so
that.
much. All right.
Although I'll tell you that the thing on that, back to that same issue, the point that I really would want to know in the area is what's the rate of dog-related rabies in the area? As I said, in Southern California and in California in general, hasn't been a dog-related case of rabies in over 30 years. So people come in looking for rabies prophylaxis after a dog bite, we're not offering it.